Morning, all you cool cats and kittens. Dr. Peterson here with Regions EMS for this month's Regions EMS update. Are you ready for a break from COVID? Because I sure am, and I promise you that's the only reference to that virulent virus that will be made right here in this intro segment. And now that that's behind us, we're coming to you this month from the picturesque Afton Alps. Why Afton Alps? Well, since it's Lovers Month, we figured the red and white crest of the National Ski Patrol would be an appropriate backdrop. And by Lovers Month, I actually mean National Library Lovers Month, otherwise known as February. And speaking of libraries, boy do we have some exciting topics to cover. We'll start off with some wisdom on managing a typical library situation, choosing an appropriate medication for chemical restraint. In addition, we'll have a lovely segment featuring some of our EMS providers and their thoughts on gratitude. And as always, I'll bring you the latest updates from the news desks. And boy, are there plenty of updates this month. So sit tight, loosen those duty boots, but not too loose. That smell knows how to linger. And get ready for the 3 things you need to know. One of the duties of being an EMS medical director is making sure that what we think is happening in the streets is actually what is happening in the streets. The fun way to do this is by responding to calls, where we get to see all of your pretty faces. Another way we do this on a regular basis is by reviewing your charts. You may not realize this, but the medical directors get real-time notifications anytime a critical chart is posted by any of you. This includes cardiac arrests, advanced airway management, childbirth, and even things like anytime ketamine or Haldol is given to a patient. We want to make sure that our guidelines and our education are actually working and helping you to make critical decisions in high-risk situations. One thing we have noticed over the last several months is quite a variation in practice with the use and dosing of Haldol, Versed, and ketamine for sedation and chemical restraint. It's important to recognize that these are 3 completely different medications that each act on a different part of the brain. Although all 3 of them are effective, whenever possible, it's always best to choose the right medication for the right situation. To better understand the nuances of these medications, we recruited one of our friendly toxicologists to help shed some light on the pharmacology and situational considerations that might be important to know about. Check this out.
Hello there, my name is Nate Kunzler. I'm a medical toxicology fellow at Regions Hospital. I'm also an emergency physician. Today we're going to be talking a little bit about sedative agents in the pre-hospital setting, some of the risks and benefits of those agents, and what you can sort of expect to see at the patient's bedside, or in this case in the field, as you use these agents and how quickly they might have an effect. The first thing to talk about is that choosing to sedate someone in the pre-hospital setting is a serious decision, right? There are lots of things that are less controlled, and you know much less about patients in the pre-hospital setting. And so, of course, as we choose to sedate them, we're taking a little bit more of a risk. And anytime you choose to sedate someone, you're effectively saying the risks of doing this, of giving these medications, are less than the risks of allowing whatever it is that's occurring to continue to occur, if that's agitation or a seizure or whatever process it is that you're concerned about. In order to then make that decision intelligently and say the risks of these medicines are less, of course, we need to talk about the risks of the medicines that we might use. So today we're going to discuss 3 main medications. We're going to talk about haloperidol, we're going to talk about midazolam, and we're going to talk about lorazepam. There are lots of other medications that I'm certain you will hear about or have heard about already that people use. I think of things like droperidol, I think about things like diazepam, and things like ketamine. While some of those drugs, like droperidol and diazepam, have some similarity to the drugs we'll discuss today, some are completely unique, like ketamine, that works through an entirely different mechanism. Those drugs are all worth discussing, and if you happen to use any of those drugs in your practice, I think it's worthwhile to have a discussion with your medical director about the risks and benefits and kinetic profiles of those drugs as well. We've chosen these 3 drugs today because they're the most common drugs that we see used, at least in sort of the services that we deal with here around the Twin Cities. So in general, there's two big classes of drugs that these belong to. One is benzodiazepines, that's midazolam and lorazepam, and one is antipsychotics, that's haloperidol. So before you decide which specific drug to give, it's often good to give some consideration to which class of drug you might want to give. There are benefits and risks to both of those, so we'll discuss benzos first and then antipsychotics after. So benzodiazepines work in general by increasing the signaling of a neurotransmitter called GABA. And what that does is you can effectively think of as it turning the whole volume of the brain down. It stops signaling pathways of all sorts and decreases, therefore, all the signaling that we see coming out of the brain, as well as the rest of the central nervous system. This is an excellent drug in some situations. In particular, I think for seizures, it's remarkably effective, and also for stimulant toxicity, because not only will it stop the sort of agitation and central effects of it, it also helps to reduce the adrenergic outflow, which can reduce the hypermotor activity and the hyperthermia we occasionally see with those stimulants as well. It does have a downside though, and that is that while alone it's a safe drug, I know we classically say like, oh, benzos don't cause respiratory depression, in synergy it can be very dangerous. So if someone's combining this with any other central nervous system depressant, and I think about things like alcohol and barbiturates and opioids as very common ones that we will see, then it can have clinically significant respiratory depression, hypotension, and even coma. So this might be a drug that if someone's very intoxicated and agitated, for instance, you might think twice about choosing to use these drugs, or maybe just choose a smaller dose than you otherwise would have. The other class of drugs, the antipsychotics, also have some really good benefits. And the place where I think these are the most helpful is in the patient who has either a primary psychiatric disturbance, like decompensated schizophrenia, or in somebody who's using drugs that also have very significant psychiatric side effects. I think about things like meth and PCP, where not only are those drugs stimulants, they also increase our sort of psychiatric fragility and can lead to significant psychiatric side effects. In those cases, an antipsychotic might be a more effective drug than a benzodiazepine. There are some risks of antipsychotics, primarily two. People talk about the so-called extrapyramidal side effects, and then there are some changes on cardiac conductance. When we talk about extrapyramidal side effects, what we're really talking about is a series of motor movements that can occur after you give a drug that changes dopamine conductance, which is what antipsychotics do. There's a sensation called akathisia, which is the feeling where you're just crawling out of your skin. You just have to move, you have to leave, you gotta get out of here. That's pretty common after many antipsychotics. And then there are sort of the acute dystonic reactions, where we see people with sort of a torticollis, where they'll twist their neck to the side, or their arm will be stuck, those sorts of things. It's important to be aware that those are pretty common side effects with antipsychotics, and you'll probably see them if you give enough antipsychotics in the field. The other big worry is, of course, changes in cardiac conductance. So in particular, antipsychotics tend to have an effect on the QT interval of the EKG. So they'll prolong the QT interval, which puts patients at risk for lots of arrhythmias, but primarily torsade. Another important thing to consider, so in a patient who already has, for whatever reason, some significant cardiac conductance abnormality that you may or may not be aware of, this might be a more dangerous drug to choose. So we've talked about then the class of benzodiazepines and the class of antipsychotics. We'll talk about now some specific drugs within those. So for the benzodiazepines, the two drugs that most commonly we see used are midazolam and lorazepam. They're actually quite different from each other. We'll talk about their administration, and in general, we're going to talk about the IM route for most of these drugs. As you all well know, in the field, IM is probably the most common way that we end up giving these drugs, although there are occasionally IV administration as well, so I'll make a note of that. So for midazolam, of all the drugs we're talking about today, this is certainly the quickest. An IM injection of midazolam should have an effect in 10 to 20 minutes, be at peak by 20 minutes, and certainly have an effect by 10. An IV injection is even quicker than that. We're talking about an onset of within a minute and a peak within 3 to 5 minutes. Typical doses you might see for this, midazolam you would consider maybe 5 milligrams IM or intramuscularly, and 1 to 2 milligrams IV. For lorazepam, the other benzodiazepine, the onset is much, much slower. So IM Ativan or lorazepam will take anywhere from 20 to 30 minutes to be effective, and IV is not much quicker at 15 to 20. So while it can be an effective drug and it does last for longer, and there are situations where it might be more useful, it's important to recognize that in the acutely agitated patient, it is much slower. Moving then away from the benzos and towards the antipsychotics, the last one we'll talk about is haloperidol. So haloperidol sort of sits in the middle. IM, we expect its peak effect to be probably 15 to 20 minutes, so a little slower than Versed or midazolam, a little faster than Ativan or lorazepam. And IV, it's very different. So the dosing can be anywhere from 3 to 20 minutes of onset, depending on how big of a dose you choose. People use anywhere from 1 to 5 milligrams IV. It's much less well studied and a bit more erratic. So as we step back, I think it's important to think about a few things. One is, think about the class of drug you're choosing and the dangers of each, benzos or antipsychotics. And then as you choose drugs within it, think about, not only is it important for you to know what the timing of these things are, but it's important to recognize that if the clinical picture of the patient doesn't match the kinetics that you know the drug should have, either there might have been an error in dosing, or you might have to step back and reconsider the clinical scenario you're in and think, maybe this person's not suffering from what I thought they were suffering from, and I need to reassess the situation. In general, the best you can do is know what you can about these drugs and try and use them safely. If you have questions about these drugs, or if the drugs that you use are different, if you happen to use droperidol or ketamine or whatever it is that you happen to use, it's important to talk to your medical director about it and say, I have some questions about our sedation protocols or the drugs we're using. How can I improve the care that we're giving to our patients? The decision to sedate a patient in the field is a serious one, but it's one that we have to make on occasions. And so the best thing that we can do is to arm ourselves with the knowledge about these drugs and the effects they'll have on our patients. Thank you. Stay safe and appreciate the work you're doing.
Tell me what you love about EMS.
Well, I think we all got into the fire service because we like helping people, and I enjoy working together as a crew to problem solve, because every call is different, and it's instantly fulfilling when you go out and can know that you genuinely touch someone or help someone in their time of need.
I love working on the community paramedic team because we help patients stay home with their families during COVID.
I like going to calls that need us to be there, and we could actually help somebody and make their day a little bit better. They're going to call us when they're in a bad spot and having a bad day, and hopefully we can come and make it a little bit better, whether it's just having a quick conversation or using some of our skills to help save somebody's life or just kind of brighten their day a little bit.
Thank you.
Hey Steve,
I didn't do it.
what do you love about EMS?
Helping people. I think the part that's the most enjoyable for me anyhow is the challenges that each patient brings. You never know what you're going to see or be exposed to, and I think that challenge, both mentally and in some cases physically, is the best part for me.
What I love about EMS is just positive interactions with different diverse types of people.
I love the uniqueness of the job and the opportunity to serve my community in a different way every day I come to work.
I like the challenges that each patient has. Every patient's a little different, so each call we can practice different skills and everything.
Hey Dr. Finn.
Hi.
What do you love about EMS?
I love being part of the team that's the first to make patient contact and help them during their time of need.
Tell me what you love about EMS.
I love serving the community, and I love having a job that gives me purpose.
Thanks for all you do.
Thank you.
Hi, I'm Dr. Peterson, and this is a Regions EMS Studio Update. It's been a while since we've done this, so there are several things that you need to know to get up to speed. First, if you use our mobile app, which you should, you may have noticed a guideline update about a month ago. Most of the changes were either clarifications or corrections, and the full list of updates can be found in the What's New page in the Front Matter section of the guidelines. There are a few changes that I'd like to highlight, however. First, all references to St. Joseph's Hospital have been removed in order to keep the guidelines current with reality. As a result of St. Joe's closing their ER, St. John's Hospital built a cardiac cath lab and are now an authorized STEMI receiving facility 24 hours a day. Since the transport difference within the 694-494 loop is minimal, you do not necessarily need to divert to any specific East Metro hospital just because it is a minute or two closer. Transport the patient to where it makes the most sense, considering their preferences, any existing healthcare system connections, and the hospital capabilities that you think will be needed. Regions, United, and St. John's are all very appropriate destinations in the East Metro. Another notable change includes a recommendation to transport cardiac arrest patients in a PEA rhythm with a rate greater than 50. These patients are more likely to actually have a very weak pulse that you just can't palpate and might benefit from some options available at a hospital. Some of you may have seen our EMS fellow, Dr. Finn, use an ultrasound device to help make decisions in these types of patients. This is a tool that we hope is going to be very useful, and we are looking into it for EMS use in the field in the future. You can read the rest of the changes for yourself, but the last one I would like to mention also involves cardiac arrest. In cardiac arrest, due to penetrating trauma, if there are any signs of life at any time for you, your first priority should be to load and go. These patients need surgical intervention if they have any chance of survival, so get them to a hospital and do it quickly. Chest needle decompression is fine, but not necessarily a magic bullet, and should only be performed if it won't delay moving towards a hospital. Same with CPR, which is even less likely to be helpful in these situations. Now, this wouldn't be an update without mentioning ECMO. The ECMO program is still alive and well, pun intended, but are still not able to respond to hospitals outside of the U of M East Bank. As usual, call the ECMO number as soon as you identify an eligible patient with a shockable rhythm, and the doc on call will give you further instructions regarding whether or not you should proceed to the U of M. We hope to have the mobile team back up and running by April at Regions Hospital at least, but stay tuned for further notice on that. There are dozens of people alive and well throughout the Twin Cities because of this program and your diligence, so thank you. And finally for this month, I'd like to recognize the work of my colleague here at Regions EMS, Dr. Carrie Haley. Carrie has been working with several of you to develop a video series and podcast discussing and reflecting on diversity, inclusion, and challenges within EMS. We don't necessarily have any answers for fixing anything, but I think it's at least important to have these conversations to raise awareness of the challenges that many of you face every day so that we can hopefully begin to make some changes. Unfortunately, many of us, myself included, are quite frankly ignorant to a lot of this. So kudos to Dr. Haley, and you can view the series on our YouTube channel, Regions Hospital EMS. That's the news for this month. Thanks for tuning in. Keep your mask on, get your shots, and stay informed. Peterson out. Okay, slowly but surely, we're working our way back to normal with these updates, although normal is always in the eye of the beholder. Over the past year, we've posted a number of video updates to keep you up to date on the very latest pandemic fashion. We still have all of this information available on our website, regionsems.com, but one thing that kind of stuck was our regular trivia question. Thanks to all of you who have participated, and here's a challenge to those of you who haven't. The most recent unanswered question was this: which virus inspired the movie Contagion? The answer is the Nipah virus. Google it, it's actually a real thing. Kudos to Jeff from Oakdale, Gail from Marine, and Dawn from Ramsey County ECC for submitting correct answers. Honorable mention to Jason from Lakeview, Brian Mueller, formerly from Washington County and now with Stillwater Police, and Brad from Lake Johanna Fire. Nice try, guys, and better luck next time. If you'd like to play along at home, submit your best guess to regionsems@healthpartners.com for a chance at fame and glory with a shout out on our next update video. This month's trivia question is this: "Beware the Ides of March" was a phrase made famous in William Shakespeare's play Julius Caesar. It doesn't mean much today, but how did the early Romans know which day would be the Ides of March? The obvious answer is the 15th of March, duh. But since their numbering system was based around the Ides, I'm going to need something a little bit more definitive. Do your own research and send your guess to regionsems@healthpartners.com. As always, please check out our other social media channels and subscribe to stay informed of future updates. Well, that's all for this episode. Special thanks to Chris Blackwell and the team here at Afton Alps for letting us borrow some space. See you in a few months, same bad time, same bad channel. For everyone at Regions EMS, I'm Dr. Peterson. Stay smart, stay safe, stay professional, and keep both skis pointed in the same direction. Man. Oh, my lips are cold. Okay.
Yeah, get that. Or get him just strutting down so that...
Oh, I've got it. Don't worry.
You got it? Okay, that's what we need.
You're rolling, right? Oh, I am.
Yeah, of course.